Hello, everyone, and welcome back to another Unfiltered Production. And this subject that Cindy and I are going to talk about today and rant a little bit about, per usual, has to do with timely initiation of care and what has happened, what we think has happened since the RAP went away. And for those of you that are on this video and don't remember the RAP, or you haven't been in home health since the RAP went away, I did not look it up when it was, Cindy, but it's been several years that the RAP went away. It was a receipt of anticipated payment. And what it was is that if you got a referral for a home health start of care, when you initiated that start of care, within 2 to 3 days after you sent in the information on the start of care, which agencies frequently tried to get out the door within 24 hours, you would receive 60% of the anticipated payment ahead of time. And so you were literally being paid ahead of time for the care that you were going to be providing in those 60 days. And at the end of those 60 days, or the end of however many days you had the patient on, when you billed, you received the additional 40%. And then if you restarted the patient, it was 50-50. That was the split. And these are on traditional Medicare types of patients. We've since gone away from the RAP because a lot of agencies were, how do I put it? They were literally working for the RAP. They were starting as many patients as they could, not necessarily providing the care that they should, and kind of living off the RAPs, and then wouldn't even bill the finals because they would just keep the RAP money and move on. But since that went away, we feel like some of the impetus on getting a patient into your agency or into an agency and started has gone away. And Cindy, I don't know if you want to share your personal story, or I can share mine first, but we know this because we know timely initiation of care was part of the study that we did an Unfiltered on before, that's changed. It's gone down. We know that about 70% of referrals to home health agencies go unanswered. They go untreated. We know certain things from the data. And so, Cindy and I both had a personal experience recently, and I want Cindy to go first because hers is even worse than mine. So Cindy, if you want to share what got us on this rant, that would be great.
Well, just to echo, we know that timely initiation of care has been a measure. We know that people have gotten into issues with it on survey when they look at making sure that you get out there timely, and a lot of emphasis gets put on it. We know that it's part of our outsource review process to look at those dates with respect to date of referral or physician ordered start of care date. And if it's been longer than 48 hours since they received the referral, if the dates aren't lining up, we recommend they just double check, was there a new order? So we know there's been a lot of work on this. Mm-hmm. Then I had a family member become ill and needed home health. And I needed to push hard to get that to happen because this individual really didn't think it was necessary, but it definitely was. And so I got consent to reach out to the physician's office, explain the situation, and ask for a referral. So I gave them a call on a Tuesday, and I was called back later that day by the physician's practice to say that, physician signed off on this. Yep, it makes perfect sense. We've sent the referral to the home health agency. I'm like, great, Tuesday afternoon, clock is ticking. So I let Wednesday go, and nobody's heard anything from a home health agency. And now it's Thursday morning, and I'm like, okay, I'm giving them till noon. I know people are busy and there's staffing issues, this, that, and the other. But noon came around and no word from the home health agency. So I gave them a call and ended up with their intake department, for which I was almost immediately informed that the referral that they received was incomplete. It didn't have the physician specifically saying what the reason was for home care, and so they couldn't follow up on it. And I was flabbergasted. I'm like, hold up. What you're referring to, and yes, I disclosed that I work in the home health space.
But they knew who you were. They knew who you were. They knew what your experience was. They knew that you understood the benefit. I think everybody.
Well, I didn't go through a whole biography. I basically said I've been in the home health space now nearly 3 decades. And what you're referring to in terms of completeness is about the face-to-face, which that requirement is, the time prior to the referral or 30 days after if you need to get updated information. I then explained that the physician in question was out of the office the rest of the week. And when I had spoken with the nurse, they were going to send an amended progress note to the home health agency upon his return that Monday. So well within the timeframes with respect to having a complete referral. Oh, no. I was repeatedly told that this was an incomplete referral, and they had left a voicemail for the doctor's office and had not heard back. And I said, wait a second, you received this referral on Tuesday. It is now Thursday. Yeah. Well, you need to get care started. You're under a 48-hour. Oh, no. That does not apply because we don't have a complete referral. Okay, hold on. So my question to you is this. Who was going to let the patient know that this shenanigan stuff was going on trying to get the referral order straight? This individual's now been sitting there for 2 days. No one contacted them to let them know what's going on.
Oh, I think we should stop right this second, Cindy, and let our listeners know this is not a Medicare Advantage referral. This is a traditional Medicare referral. Go ahead.
Traditional, straightforward. Let's go get this done. Then she told me, would you like to speak to my supervisor? And I'm like, absolutely. So she took my name and phone number and assured me that the supervisor would call me to explain why this was delayed. When I hung up, I immediately called the physician's practice back and left a message for that nurse saying, we're running into some issues with the referral. You can give me a call. I'd appreciate it. 30 minutes later, my family member is, I'm talking to her about something else, and I get a call from the nurse at this home health agency saying that she's having trouble getting a hold of this family member because she needs to schedule the admission. Half an hour after I talked to the intake department, knowing the physician is not physically available till Monday, you magically got a complete referral and put it on the schedule and got it ready to go. And the supervisor never called me, has never called me back at all. Just magically this happened. And you know who I called then? I called you.
That's right.
You have got to be kidding me. So I totally get it. And we work with our partner agencies on the outsourcing side about a complete face-to-face. We know that you need to have a complete referral. The days of, just go with a name and an address don't work.
Hang on.
Information.
See, those days were in the land of the rap.
Yes.
In the land of the rap, all we had to get was a slight scent of a patient, particularly a traditional Medicare patient. We just needed to know their first name, probably spelled incorrectly, and where they lived to go out and see a patient, because we knew once that clock started and once we got them in, we were going to get paid 60% of a full boat of this episode up front. And so we would go out with a verbal order. We would go out with calling in doctor's office and getting an order. We would go out however we could. We were incentivized to go out. So finish your story. Sorry.
But that then I looked at it and said, but where is the human factor in this? You have an individual with a significant medical condition, multiple comorbidities, clearly homebound, functionally challenged due to this illness. You don't even call them and let them know what's going on with the referral. I mean, and then I forgot the part when intake informed me that I could just take this incomplete referral to another home health agency if I chose. And I'm like, wait, okay, that's not the best customer service to suggest I go elsewhere. But to have all of that then magically fixed in 30 minutes was like, there's no way you got what you just said was incomplete. And what would you have done had I not called that day? I mean, would that have just been this person sitting here for days on end, not getting care, waiting for this to happen? Because if you're waiting till the doctor comes back, that would be nearly a week since you got that referral before you go. And there's no informing them. Why? Because technically we have an incomplete referral. So technically the 48 hours doesn't apply. So technically I still look good as an agency for timely initiation of care. And I was just furious that this is just not how this is supposed to work.
In the interim, didn't you receive a call from an outpatient clinic for her to come?
Yes, my family member did. An outpatient clinic called and said, you need to come for your outpatient PT for your back pain, which isn't even the issue. I don't even know where that referral came from. Nobody asked for that referral. I said, just ignore it. You can't get there anyway, so whatever. But I mean, why does it seem, Sherry, that we aren't alone in this? I'm sure our listeners have had more than their share of a family member or a friend try to receive medical care, and you end up the bad guy in there trying to make things happen because they're not happening on their own. Whether it's while they're in the hospital or trying to get home care or wherever, you're like, how do people that don't have family members with this level of knowledge get decent care at all? Because it seems like you have to butt your head against the wall, because you would think, okay, maybe it just happened to Cindy Kraft, but what happened on your side there, Sherry?
Well, my situation was, it was my dad, and he had a hip replacement, and I was in the hospital when they came in to do his discharge planning, and he happens to be on Medicare Advantage, and so it was really interesting because there was no choice offered to him about what agency he should get. He was told, the discharge planner walked in and said, "I've called such and such agency; they'll be out to see you in a couple days." And so I'm sitting there going, wait a minute, they're supposed to offer the patient a list. They're supposed to give them the choice, and also let them know about home care compare, and just to let you know, Medicare pays for discharge planning. I know those of you that didn't know that, you're going, they do what? Yes, they pay the hospital an extra bit for their discharge planning process. And literally his discharge planning process was, we sent the prescriptions to your pharmacy, and this agency will be out to see you. Well, I happened to get there, and the gentleman did call, and came out. It was a therapy only. And I happened to be at the house and witnessed, he got there in time, but let's just say the care was less than what was appropriate. And I say that there were no vital signs taken on the first visit. There was no assessments of any sorts of transfers, even though my dad reported that he had already showered. There was no visualization of his shower, or how he was safely getting in and out of the shower. And there was not a bed transfer. There was not a manual muscle test. It literally wasn't a visit. And it was to the point that I'm sitting there as a therapist, and the gentleman knew I was a therapist, or as a PTA, and he knew I was a therapist, and he still didn't do those things. And I would have called Medicare. That's just what I would have done. I would have called the 1-800-Medicare and reported him right away. My dad doesn't want me to do that. And a lot of us sitting here are saying that there's a lot of family members that don't want to get involved. They don't want to rock the boat. It's just that it's a generational thing. Subsequently, he had visits where there was never a walk outside of the house. In the 8 or 10 visits that he had, there was never the type of care. There was never a notification that he was going to the doctors, and they knew he was going to the doctor the next morning. They didn't even check the car transfer. There was so yeah, they got there in time, but then what happened? It wasn't even appropriate care. And I say that because that's the second hammer of this thing, is that they're not only are we as agencies not getting to patients in time, but then what are we doing once we get there? What are we doing? And are we doing evidence-based tests? Are we doing the things at the bare minimum of what we learn to do as clinicians, nursing and therapy? This just happened to be therapy, but nursing and therapy, are we doing the things that we learned? Are we assessing the patient for any other thing other than maybe what's on that intake piece of paper? And those of you that lived in the RAP environment and then had to make that transition, I applaud you. I did not stay in my agency that I own long enough, because I knew that business model would not work for my agency, because you are being expected to provide 30 days of care without a single payment or an ability to pay on traditional Medicare, which to me is absurd. It's literally absurd. And we've seen some of the ramifications of that with the throwing of the money from the PEs, the equity companies, and the hedge funds. They're jumping into home health with both feet to help these agencies afford to provide that care. And Cindy, I go back to your story. The outpatient clinic called before the home health did, because the outpatient clinic can bill every day. They get paid on fee for service. And so the minute that patient walks in the door, they can create a bill that day if they want to, and with realistic expectations of being paid within 7 to 14 days for that visit. Home health has switched so far into the land of unreality that you have to wait 30 days, not just wait, but you have to spend money for 30 days before you receive a dime. And that's all because of the things we did when it surrounded the RAP, and the advantages that we took when it surrounded the RAP. But I think that we need to look at ourselves in a really realistic vein and say, now have we swung too far to the I'm going to delay the care of this patient to the point that they're either, number one, going to pass away, number two, go away, or number three, fight like hell to get care like you had to do for your family member. I think that we need to take a realistic look at that.
Well, I think also part of that is when I get asked about, how do we better manage utilization, which always makes me nervous about what are you talking about? Because we know it's overwhelming to have so many people there in that first week. I mean, shouldn't we spread out the therapy and have like PT in the 30 days and OT in the next 30 days? And I'm like, oh my gosh, So before, not only did we have the wrap, but before PDGM, therapy was like, you need to get out there right away. You want to get out there right away. And now it's overwhelming. It's too much. We should just get to it eventually. I mean, when they did call to schedule the admission visit, they did let my family member know that it was nursing, PT, and OT. And there was a question about, well, why do I need OT? And the nurse said, can you dress yourself? And they said, yes. And then they said, well, you don't need OT then. And I'm like, okay. Just because the person's not naked doesn't mean they don't need OT. The same issue of the only bathroom in the house is up a flight of stairs. So is the bedroom, endurance issues, fall concerns. And that was all taken care of by saying, can you dress yourself? Over the phone. I mean, we don't even know what that would have looked like or how that got done. So this whole thing also, I think, Sherry, is coming in with this, don't overwhelm them. Don't do 2 therapies. Spread it out more. Really, where is the patient in all of this? I think we've had to right size. Yes, the wrap happened. It got taken advantage of by some people. They ruined it for everybody else. Then we had the therapy thresholds. We know what happened there. That got ruined for everybody else. But now we've got to just say, okay, wait a minute, whether it's timely initiation of care or how I'm utilizing my therapies, put the patient first.
Yes.
If you can get to it, if you have a staffing challenge, if you really don't have the information you need from the doctor, why can't you let the patient know? The prospective patient know, this is what I have, this is what we're working on. Why let people, I mean, and there was no follow-up. So me nagging my family member is one thing, but I'm thinking this person lives alone, has no nearby caregiver, and you gave them no instruction, like at least if this happens, you should go, we can't get to this right now. This is what we're doing. If this, or this happens, go to the ED. I mean, that's not going to hurt anybody's ED rates. They're not even your patient yet. But from a patient safety perspective, you leave them with nothing until you get around to it. Right. Where is the patient? And on the therapy side, yeah, the glory days of, give everybody 3 times a week and see them for the entire cert period. No, we should have been doing better and really dosing ourselves appropriately. But this whole, now they can't have 2. And I do audit, Sherry, where now every therapy is provided 1 week 9, once a week. Somebody just got out of the hospital with this, that, and the other wrong. And 1 time a week is good enough for everybody. I think we just have to get our arms around the reality of this and put the patient first. And not because they're related to you or related to me. I worry about the ones that don't have that kind of advocate, what's happening to them.
And advocate for the profession, guys. Advocate for the setting. I mean, we need to have some way of getting our agencies paid during that initial 30 days, because it is obscene to think that you are spending money for 30 days without receiving any money in return, without receiving any payment in return. It is obscene. And what agencies are doing is they're making those bottom line decisions and metering out what they can afford to meter out during that initial 30 days. And I think it's super important that we know that there used to be another world and there can be a happy medium. Wraps were over here on the pendulum, and this 30-day wait, well, it actually turns into 45. I just should tell you that, because once you submit the 30-day bill, you have a waiting period of 10 days before they're going to pay you. It's super important, but now we're also dealing with Medicare Advantage. That is over 50% of what referrals you're receiving. But at least in Medicare Advantage, most of them you can charge per visit, and you can get paid in a timely manner quicker. So I think that we have to look at what has occurred historically and see if we can get it back to some realm of reality, and understand that these folks are sitting in that house and they're just waiting for help. That's all they want. They just want help, and they want to make sure that they can stay in their home. And your family member lives alone, and is fairly active, actually, has some health concerns for sure, but fairly active. And she's a poster child for somebody who should be at home, and they should not be in a facility. And so I think that we got to remember why we're here. We're here as a benefit to keep people out of those expensive facilities. And if you look at what's going on in the skilled nursing space right now, not to get us too much into the mud about a whole different issue, but they're getting mandated about their coverage. They're getting mandated about who's going in and who's doing that care. They had gotten away from using nursing as their primary RNs, as their primary care in the nursing home and gone to an LPN model because it was less expensive. So there are staffing issues and challenges around that, and they fought it tooth and nail. But now they have a mandatory amount of nursing that has to be RN, licensed nursing, that has to be in that facility every day. So we don't want that to come to home health, but it could. And that's one of those things that we have to be aware of as we look on the horizon. And Cindy and I get on these rants, guys, because things happen, and they happen. And when you know the rules, like we know the rules, it's hard to watch. It's hard to see it. And when it happens to you personally, when they know that you know the benefit and they still do it right in front of you, that just tells you how brazen it's become. And Cindy, do you have any closing thoughts that you want to share with folks about this issue?
No, I just think, there's so many things we have to juggle to be a successful home health agency. And it's hard, and there's always challenges, but I think, again, we do need to keep the patient in this conversation, to communicate with them, to let them know what's going on. We're not saying, we should, hand carry everything, or, oh my gosh, if they're related to so-and-so, something should happen differently. But we really just want to make sure that we're not losing track of the people in the middle of all that paperwork.
Thank you so much, Cindy. And if you enjoyed our rant, if you enjoy our Unfiltered podcast, if you want some free home health information, this is always on our YouTube channel. This will be uploaded to our YouTube channel very soon. And if you subscribe, you'll get notified when we upload new things. So hopefully you'll make the decision to subscribe. And if you have any questions, you can reach us at www.knkhelp.com. And KN is in Nancy, K, help.com. So thank you all for listening, and be safe out there.